The beginnings of this pandemic really didn't happen in Wuhan. Problems that we're facing and started months, if not years before.
What do we do? How do we protect our seniors? How do we protect our workers?
I mean, COVID's affected everyone. It has affected everyone.
You don't have time to be scared. You don't have time to be sad. You just have to keep going.
We were on our own.
In the year 2020, a virus from China, COVID-19, spread around the earth, killing over 2.5 million people. The pandemic turned a spotlight on long-ignored and inconvenient truths about our society. The seeds of this disaster were sown by years of government neglect and cultural blind spots.
So our advice right now is there is no need to use a mask for well people.
Do we value the lives of our seniors? Do we acknowledge the contributions of frontline workers in care homes? Was there any avoiding this crisis in care? Canada's long-term care nightmare started with a COVID-19 outbreak in North Vancouver, British Columbia, on March 5, 2020. Over the next year, more than 200 BC care homes and thousands of healthcare heroes went to war with COVID-19. This is their story.
I think going back to the summer of 2019, when I appeared before the House Standing Committee on Health, I used 3 words to describe the continuing care sector, and that was understaffed, under-resourced, and under pressure. So I think to understand what's happened over these past few months in the midst of the pandemic, we really have to understand what the context was before we even got here.
Meeting number 150 of the Standing Committee on Health. Sorry we're late, but a little bit of chaos these days that we have to deal with. So,
Mr. Chair, honorable members, our continuing care sector is in a state of crisis. The last Health Human Resources Strategy was originally authored in 2004. We're 2019 now. Our care providers are understaffed, under-resourced, and under incredible pressure to provide quality care to an increasingly complex population.
I think the beginnings of this pandemic, the problems that we're facing in British Columbia, started months, if not years before. We knew going into this pandemic that even the slightest and the smallest of crises that were to happen would put the system under an incredible amount of pressure.
Unfortunately, COVID-19 definitely exposed those challenges and exposed our gaps within our sector.
Residential care homes have had several vulnerabilities. How we have designed these buildings in long-term care are based on efficiency, staff efficiency, and biomedical approach rather than a social model of care. Multi-occupancy bedrooms that have been an issue from personalization, autonomy, dignity, privacy for residents. Those have been challenges.
There was report after report after report talking about a shortage of care workers in British Columbia. There were simply more people leaving the sector and retiring than there were coming in.
Safe Care BC is the Workplace Health and Safety Association for the continuing care sector. Our focus is to make sure that everybody who works in that sector goes home safe and healthy at the end of their day.
In fall 2019, we were struggling to get personal protective equipment out of Asia to supply our care homes. At the time, we were being told that it was being directed to the health authorities and whatnot. And I think many folks just dealt with that as another challenge, but they didn't really think about what is the root cause, why is that challenge really happening?
I'm an infectious disease modeler, so my research has been in the past, over the past 10 to 15 years in modeling infections, how they spread, but also how they evolve, and really trying to understand transmission of different pathogens. SARS-CoV-2 is a beta coronavirus. Coronaviruses can infect and inhabit many different kinds of animals. The closest relative that we know about was sequenced from bats. So there may be a bat to human, or maybe indirectly, very likely in the Wuhan region of China in November or December 2019. One of its superpowers is this ability to transmit before people show symptoms, or possibly without symptoms.
At the end of January 2020, Canada's House of Commons called an emergency meeting to discuss the country's state of pandemic preparedness.
Today before us we have Teresa Tam, Chief Public Health Officer. Welcome.
For sure, in the general population in Canada, the risk is low. But in the severe end of the spectrum, there's more people who are older and with underlying medical conditions. So that is a key observation. Is it possible that an asymptomatic person could transmit the virus? Even if it's possible, it is, we believe, a rare event. And it is not that type of transmission that drives the force of an epidemic.
So this morning, we're here to let you know that late yesterday, we had our first case of a novel coronavirus confirmed in a person here in British Columbia through the work of the BC CDC Public Health Lab.
First sequence was released very early on, and there were already modeling estimates in January of last year. And I got interested in those and decided to have a hackathon event here at SFU. And that kind of got us into our first analysis that we did around transmission happening before symptoms. There were these two data sets that allowed us to estimate how much transmission might be happening before people even know that they're ill. And even in those very early days, that was considerable. We found about 40%. The remaining transmission happening before symptoms is up to 80% of the transmission events before symptom onset. So that was already a sign that this was going to be a very hard to control virus.
Why was this vital information not acted upon by the health authorities?
Coherence and in response is really important. Otherwise, the public will be confused.
This is serious. This is our generation's Spanish flu. And I remember thinking about, okay, what do people need to know right now? They need to know that there is this virus. They need to know what it is. They need to know where to go for reputable information. They need to know just the basics on infection prevention control.
My first real action in all of this was an email that I sent over to the Ministry of Health, which effectively was being directed to the provincial health officer, Dr. Bonnie Henry. And I wrote an email and said, look, there's this coronavirus. I'm hearing about it. I'm nervous. I think we don't have enough communication flow, and we don't have enough information flowing between the private care homes and the government and the provincial health officer. Let's get prepared for this. Let's pull that SWAT team together. And I was quite surprised at the response I got.
As you can imagine, a number of things are underway in BC related to the coronavirus. We don't currently have a table for communications with stakeholders, such as the long-term care sector. I understand from the Provincial Health Office that clients and staff in care facilities are not currently considered to be a group that would be at risk, although this is a rapidly evolving situation. The Provincial Health Office has confirmed that if there is a need to connect with the long-term care sector, the BC Care Providers Association would certainly be included.
I think I know enough about respiratory illnesses to know that the people who are going to be the highest at risk of dying are people living in long-term care. And it's quite shocking to me that we didn't think, even as late as January, the Provincial Health Office did not think that seniors were going to be at risk of this particular illness.
And then we started to roll into February. And one of the things that was becoming increasingly apparent, especially in those early days, was just how widespread the issue of PPE shortages was becoming in the continuing care sector. We saw early signs of this in January where, long-term care homes were being short on their orders, so they'd order a certain number of masks and they get less than that. We started to hear chatter from commercial suppliers that they were rationing their supply and they were triaging it for hospitals. And so we started digging into this issue, and what we found was quite frankly concerning.
We had some sporadic detection of cases here in BC. At that time, they were testing people who were symptomatic healthcare workers and people with international travel from affected areas. We had the dental conference in BC, and that's, I think, seen as the time that community transmission did start to take off in BC.
Suddenly, the attention shifted so intensely on long-term care. Just over a week after we saw the Kirkland, Washington outbreak, we had our first outbreak in Canada, and that happened at the Lynn Valley Care Centre.
My name is Nourish Kaur. I'm the administrator for Lynn Valley Care Center. The differences you make, you see every day. And not just me, all of our staff, we all strive to make every minute of their life better. There's high demand to get into our facility because we are well known for providing good service, especially to the North Shore residents, in North Vancouver and West Vancouver. With the news coming out of China, and then quickly after that, all over Europe, we knew it's out there, the danger is out there, but the stories, basically the facts we got about the science of it kept changing. On March 5th, I got a call from Vancouver Coastal Public Health informing me that one of our staff has been basically diagnosed with COVID-19. This virus, the viciousness of it, it was nothing we've seen before. Like the strength and the rapidness of spread. But it was very scary to see both residents, especially the residents, how quickly they got infected, how quickly we started losing them from the time that we found out they're infected. Some did not last even 36 hours.
My God, how are we going to help these people? What do we need to do next? How difficult and scary and heartbreaking that outbreak was, because not only did they have the bad fortune of being the first outbreak, they were the most public.
I come from a country where I've been through a bloody revolution, 8 years of war, but I could tell you right now, this has been the hardest period of my life because you're so close. I served the gentleman his dinner in his room, and he looked fine. I knew he was infected with the virus. He looked fine, hi, we talked, only to come back the next morning and having to take the morgue technician to their room to put them in a body bag. 53 residents tested positive and 26 staff. And then we did everything we could, but we lost 20 of our residents.
There was a lot of panic, in particular around that initial site. Staff weren't showing up for work. Families were calling desperately to pull their loved ones out of care. We had a very serious situation there at Lynn Valley, and we weren't really ready to deal with it. It was the first one that happened, so we were kind of essentially making things up as we were going along.
As soon as we saw the Lynn Valley situation, as soon as we stopped pointing the fingers at the operators or pointing the fingers at the healthcare worker that might have brought in the virus, as soon as we stopped doing that, then I think that was our moment as a society together to say, this is a very vulnerable population. They're living in close proximity. We could have had our heads in the sand and ignored the reality of that elephant that was in the room. It was coming. And you could see the progression moving from the North Shore into Vancouver and then eastward. And we knew it would eventually come to the Fraser Valley.
There's been a number of community exposures and, coming up onto this weekend. The last two cases really are the most concerning to us. These are two people who are residents of the Lynn Valley Care Centre, and they were identified as part of our investigation of our community case. Consider having virtual gatherings, to consider not coming together, particularly if you have people in your gathering who are elderly, who are more
Just take it. It's okay.
who are more susceptible to having severe illness from this disease.
The government's response to the Lynn Valley outbreak was swift.
Today, in addition, we have taken the extra step of declaring a public health emergency in the province of British Columbia. We've taken a number of unprecedented measures in the last few days, and this declaration of an emergency enables me to be faster, more streamlined and nimble in the things that we need to do.
Among the emergency measures, the BC government imposed public health orders and policies to limit the virus's spread. These prevented family members and visitors from entering long-term care homes, suspended resident rights, discouraged hospital transfers, and limited frontline staff to working at one care home. Imagine you are drowning, and the lifeguard throws you thousands of pages of changing policies before a life preserver.
We were actually among some of the first who initially pushed issues around staff working at multiple sites, and this came right out of Lynn Valley, where almost immediately we had multiple exposure events in other locations because staff had worked in Lynn Valley, and then they also worked in an assisted living residence, or they also worked in a different care home on the North Shore.
At times, I didn't know if the provincial health office was directing things, if the Ministry of Health was directing things, if the health authorities were directing things, if WorkSafe BC was directing things. I would argue that really nobody was in charge. We were advocating those things, and then sometimes it would take 7, 10, or 12 days later, and then they would become part of a Dr. Henry news conference, and they'd be implemented. If we were at the table, if long-term care, BC care providers were at the table actually not having to communicate through multiple channels to get to the decision makers, whoever they were, I dare say we would have been able to accelerate the response time. Well, I naively believed that if there was anyone in the province that Dr. Henry would want to talk to, it would be the very people trying to protect those elders, those seniors. And that didn't transpire. It just didn't happen. We got the province to agree to have 3 meetings a week, almost 2 months after that initial email back in late January. So we're just at that point in March now, starting to figure the pieces and get everything together. And then it was like a bomb. Everything just went so rapidly there in that period of a couple of weeks. Much to my amazement in the discussion, there was an assertion being made from the province that somehow the majority of care providers were all connected into some provincial health network. So we had to quickly explain and educate and tell the provincial health office that no, that wasn't the case, that these care providers were on their own. They wouldn't be connected into a provincial PPE network. They wouldn't have access to a stockpile of protective equipment, that their staff could be vulnerable, that the long-term care seniors in there could be vulnerable.
When you put your orders in for your usual quota of surgical masks or medical masks, you were getting a fraction of the number you normally were supposed to be getting. And what we ended up finding when we dug into that issue a little bit more is that globally, there were major challenges with the supply chain, and specifically the commercial suppliers were rationing their supply to ensure that hospitals and acute care facilities got their orders in fully supported. And then they kind of triaged down the list. The provincial pandemic supply chain at that time did not include the entirety of the continuing care sector. So effectively, if you were a privately operated nonprofit, for example, you didn't have the backstop of the provincial supply chain to help you if your own supply chain started to fail. So this was obviously something where we were working with the Ministry of Health on flagging the issue for them, saying, This is going to become a problem if we don't take action to address it. One of the key challenges that we had going into the first wave of the pandemic is the PPE requirements for working in the context of the pandemic were so much more above and beyond what was normal practice, what's normal practice in the day-to-day operations of a care home, for example. When we talk about the tools that we use to prevent infection, to protect people against COVID-19, there's really a few core things that are in the toolbox, so to speak. You'll wear an isolation gown, you'll wear gloves, you'll wear your eye protection, and you'll wear, depending on what you're doing in the situation, you'll wear a mask or an N95 respirator. That's your basic kit. And when you go through the process of putting on, so donning or taking off, doffing your PPE, you have to wash your hands at multiple times throughout that process. So having access to hand sanitizer, alcohol-based hand rub, or soap and water is really important and should be considered part of your PPE kit. When we ask care workers to provide care with inadequate PPE, we are putting them in an impossible situation because we're asking them to choose between their duty to provide care and their duty to take care of themselves and their family members. And that's a position I don't want anyone to ever have to be in.
Lack of access to PPE put frontline care workers at risk. Warlito Valdez was the first British Columbian frontline care provider to die of COVID-19 on April 5, 2020.
When you're working in an environment with COVID, a proper donning and doffing of PPE, you burn through a lot of PPE if you're properly using it. At the time, we were told not to wear PPE unless there was symptoms. The government was saying, leave the PPE for the hospitals, not the frontline workers at the time. It was for the hospitals. Warlito was born in the Philippines, and he had worked in the Middle East as a nurse. His credentials were not recognized in Canada, and so he aligned with a caregiving profession, which is a support worker in the homes. His partner lived here. They decided to stay in Vancouver and Richmond and started building that life here with their daughter and wanted to raise their daughter here. He was working in the evening with one of the individuals, and he was helping this man eat because this man doesn't have use of his hands. And this man started choking on the food that he was eating, and Warlito, without hesitation, reached into this man's mouth and pulled out the food. Otherwise, this man would have died. And his coworker said that he looked at her and said, I hope he doesn't have COVID, because he got sprayed on his face. The next day is when we found out that that individual had COVID. And immediately, everybody in the home, started wearing PPE. Warlito was planning to come back, but he said he still had a few symptoms. So he was gonna take a few more days before coming back to work. He was on day 15 when he died, but he died saving somebody's life without hesitation. His daughter, she'll know her dad was a hero. He was. He saved somebody's life, and he died for it. The day after Warlito died, we were told, you're on your own from Vancouver Coastal Health and finding PPE. I guess I've always relied, I always thought there was a safety net, and I realized there wasn't. And that floored me. It was incredible that we just couldn't find any. There was a little store we had heard that somebody was selling it out of the back of their store, some PPE. It was kind of hard to buy from somebody who was profiting over misery, but I didn't have the luxury of being selective. I was just thankful that there was somebody. I remember buying boxes of masks out of the trunk of somebody's car in an alley. $100 a box. I was texting them and said, I'll meet you here. And, you know, again, it was a dirty back alley in Richmond, and they showed up. But I remember them popping open their trunk and they had a whole bunch of PPE in there, and it was like gold. The day he died, Orlito called 911. And this is a man who wouldn't reach out for help unless he really needed it. And they told him to take a Tylenol, not go to the hospital. And he died a few hours later.
Government's emergency plans were primed to protect the hospitals at all costs. At the end of March, long-term care staff woke to a horrifying surprise. A new policy handed down by the health authorities instructed them to keep residents infected with COVID-19 in the care homes rather than send them to the hospitals. A script was provided to talk desperate families into agreeing to these terms.
I want to share with you what we know about how COVID-19 affects seniors like your mom. We know it is particularly serious in seniors. While each situation is different, the safest and most comfortable place for most seniors to be cared for is in the care home. Doctors have learned that there is no benefit for most seniors with COVID-19 to go to the hospital, and they do not survive intensive care when they get that sick. I'm sorry to have to tell you this.
Long-term care homes, unable to send COVID patients to hospitals, were suddenly required to act as acute care providers. Under the emergency orders, the rights of seniors and healthcare workers were swept aside.
It's clearly ageist to deny a senior the right to enter a hospital for medical care. What we saw during the pandemic was a stripping of seniors' rights. They didn't want us to actually preserve that life if we could, to protect that life. When I say they, it was the heads of medical services at the health authority level, that they were expecting people to change their degrees of intervention. People should be able to get their supports that they want at the end of life. And we were gonna take those rights away from seniors and encourage them to not be transferred to a hospital. You can all walk into a hospital right now and get care. A senior living in care, in long-term care, doesn't have the right to go into a hospital for care if they had COVID. That makes no sense to anybody.
I think we ran into, what I call an ethical dilemma. We believe in patient-centered care, resident-centered care. The needs of the resident are primary. In a pandemic, the ethical framework that our province has written is different. The needs of the community are primary. A long-term care home is a community. People live there. They have their meals there, they receive care there, they do social activities there, they receive visitors there. So when we have one person who's infected, the decision is, do we move that person or not? The other side of that argument is, what about the others? And so that's been something that's really weighing on my mind. For people that live in long-term care, I just have to ask, if you lived in long-term care, how would you feel about somebody with COVID being in your neighborhood, which is in our home just down the hall? Does that make you feel safe?
As I've said many times, we need to do a better job of caring for the people who built this country. The greatest generation saw us through World War II. And we need to be there to support them properly through this global crisis.
Langley Lodge would become the site of the largest COVID outbreak of BC's first wave.
It's such a rewarding sector. It's such a joy to work with with our population in long-term care. That's why we're all there. It's a passion for the work that we do and the people that we serve. We had 51 resident cases and 15 staff cases. We lost 26 residents. We found ourselves having to turn our residents into sort of a MASH unit in, the space of a week. And it was, 12-hour, 14-hour, 18-hour days. We had one worker who had come to work. He had symptoms, but he avoided being screened. Unfortunately, he provided care to a lot of residents, and all of those residents became infected. Nothing prepares you for something like this. And the behavioral unit was one of our biggest, challenges, because it was impossible for us to isolate those residents.
It's a challenging outbreak at Langley Lodge, and we've said this before. One of the most affected units is a dementia unit, and we know that it's incredibly challenging when people have dementia to be able to ensure that they're wearing a mask, that they're staying in their rooms and things like that. And that has been part of the tragedy that's happened at Langley Lodge.
I just want to say that today I talked to Debra Hauptman, who's the director of Langley Lodge, and I just wanted to reach out to the people working there and to Debra, who has worked her guts out for the people of Langley Lodge. I think a care home that, by the way, is generally regarded in independent reports as an excellent care home, and it shows us why we have to be vigilant.
Because of the spread of the virus and the number of staff who were getting sick, as well as residents, a lot of our nurses left their jobs and walked away. And none of us were prepared for that. We have a contractor, and they hired 34 housekeepers. They interviewed, hired, orientated, put them to work. They lasted one shift or less and quit, because they said they couldn't do it. Trying to, have residents in their rooms for 63 days, having 3 meals a day in your room for 63 days. I mean, how many of us can even imagine what that must be like? And our rooms in long-term care are big enough for a bed and a chair and a TV. And that became their space for 63 days. We didn't have the right PPE. We weren't receiving supplies. The problem was that a lot of things were stuck on ships. My staff were doubling up on gowns because they felt that these gowns weren't protecting them adequately. And we found out on May 4th that we had the wrong gowns. We couldn't get goggles. We got those through Safe Care. Distilleries were sending us hand sanitizer, in whiskey bottles, literally. Whiskey bottles, and the hand sanitizer smelled like whiskey. We weren't prepared, simply were not prepared.
We were starting to receive SOS calls, basically, from care providers saying, we've run out of hand sanitizer and we can't source it anywhere. We've run out of surgical masks and we can't get them from any supplier. Any supplier that we go to will either say, we won't take you, or we don't have any. 70% of continuing care organizations were looking at a supply of 3 days or less. We've got an audience, a community that's in critical need of something. And we know that there are non-traditional stockpiles of PPE out there in the greater community. We know that contractors use N95 respiratory protection. We know that hair and nail salons use surgical masks. We know that restaurants use vinyl and latex gloves. So how can we get access to those non-conventional supplies? And that led to the creation of Operation Protect, which started as this little kernel of an idea and ended up blowing up into this province-wide initiative that took in about 1.25 million items of donated PPE, some of which went into the provincial supply chain, and some of it went directly to care providers who, at that point in time, had no other option. They had no other resources available to them.
It just made me choked up, because like 3 or 4 staff would come to the door and they were in hazmat suits. And I said, where did you get the hazmat suits? They got hazmat suits at Canadian Tire. They were wearing hazmat suits, goggles and masks and gloves and 2 gowns over top of that. That's the level of fear that we had in our home.
What essential medical supplies beside N95s does Canada get from the US that are needed for this pandemic?
I'm going to have to get back to you on that.
Debra Hauptman wrote the first of many reports on the impediments and challenges faced by long-term care homes during the pandemic. This was followed up by a report commissioned by the BC Care Providers Association that looked at the experiences across the sector. With the first wave in the rearview mirror, the public finally got a detailed look at what was really going on behind the scenes of BC's seniors' care system and the full impact of the public health response.
This is a once-in-a-career experience, and there has to be some learning from what we went through. And, it has to be documented. I wanted it as a way of sharing our experience so that others can learn from it. And I wanted to document it so that we could develop recommendations for the next wave that everyone was talking about.
Let's give the government some recommendations that are easy to implement, that really focus on building on the Team BC approach that we enjoyed with the Ministry of Health and the health authorities and other officials, as well as the sector.
We were fortunate to work with Dr. Carol Estabrooks from the University of Alberta, and she aligned for the care providers a review panel. The entire panel were 6 academics who were very familiar with the field from across Canada. The objectives of the report were to identify the factors that contributed to the spread of COVID-19.
We heard a lot of stories and how the situation is impacting care providers, so those in long-term care, assisted living, independent living, and in home care as well.
And the messaging early on was that this pandemic and COVID-19 would not impact seniors in care in BC. I think that there was a delayed start to supporting the sector, which impacted seniors and seriously impacted workers.
We were already in a very, very thin sector with respect to staffing. And in a situation like this, there isn't room. There isn't a pool of people that are sitting there waiting to be called in or available. It was already a very, very broken, weak system. It is absolutely heartbreaking. One of the providers we spoke to that had an outbreak, she shared with us that seniors ate alone in their rooms for 2 months, and that breaks my heart.
So actions of the province to limit the transmission of COVID-19 had significant impact on the rights of seniors as well as on staff.
Among other things, BC's Long-Term Care Resident Bill of Rights promises seniors in care the right to the promotion of their health, safety, and dignity, be protected from abuse and neglect, pursue social, cultural, and spiritual interests, receive visitors and communicate with them in private.
While the emergency health order superseded both staff and resident rights, including the Resident Bill of Rights, providers reported that seniors' quality of life was severely diminished. Very limited recreation or no recreation. No access to the outdoors for prolonged periods of time. Some residents are losing weight because they are socially isolated. The focus was on the virus and not on the people.
Some of the solutions have also created more challenges as well, particularly, I think, with respect to health human resources.
Staff is exhausted. They've put off vacations. They've not had coverage, so they've worked tirelessly throughout the pandemic. I don't feel that frontline workers are valued for the role they play in caring for our most vulnerable citizens. The providers indicated that they did not know which body had authority. So in a case where a directive was given or a directive was changed, providers didn't always know which authority or which directive they should be following.
It goes back to just the raw sadness of this. We've seen everybody, no matter their role, trying so hard to support this. I think maybe the key piece to remember at the end of the day is that this really is about people. Our whole system is designed to be about the people, and I hope that can remain our focus.
The BC Care Providers Report recommended a series of steps to limit the damage of COVID-19's second wave. Among other things, they suggested implement rapid testing, establish a more coordinated provincial response, clearer public health orders, solutions to the long-term care staffing crisis, accelerate funding to pay for rising COVID-19 costs and salary increases for frontline workers. The BC government commissioned their own report from Ernst & Young to review the first wave response. Instead of sharing the report with the public in time for the second wave, BC called an election and kept the report a secret for 3 months. Meanwhile, COVID-19 spiraled out of control. At the start of the second wave, there were 153 deaths in long-term care. By the time the government released the Ernst & Young report in January 2021, that number was 773. The secret report confirmed significant communication problems, inconsistent infection control practices, disorganization, pre-existing labor shortages, and health authorities favoring themselves on the distribution of PPE and other supplies over private and non-profit care home staff and residents.
If I look back to the middle of October, when we were sort of crawling along around 100 cases a day, and we seemed to be holding our own, and I think I underestimated, and maybe we all did, how much people were actually getting together over Thanksgiving, over the weeks before that, and we had that rapid takeoff in the end of October and into November, and in hindsight, maybe we should have done more then, but it was really hard to tell.
We knew we weren't immune. We knew we were going to reestablish contact patterns. We knew this virus could spread when we congregated indoors together. We knew all of that. On the other hand, the shutdown we did, that crushing that curve was very damaging, and we needed to reopen, and we needed schools, and we needed our businesses, and we needed our provisions, and we needed. Those needs were genuine, and they were right, and they were true, and they were clearly articulated. But none of them actually meant the virus did not spread when we congregated together indoors.
I don't think it's surprising that we're in a second wave. I mean, historically, if you look at the patterns of pandemics in years past, there is always a second wave, and sometimes there's a third and a fourth. I think our challenge is really, how big are those waves going to be? Is it going to be a tsunami, or is it going to be a ripple? And that's where our focus needs to be.
Sites that went on outbreak were seeing overtime costs that were just through the roof, because you have half of your workforce on quarantine, many of which were asymptomatic, or some of which hadn't been tested for COVID, but were told to just quarantine and self-isolate for 14 days. Well, that meant that you didn't have you were already stretched thin as it was in terms of the workforce, but now you really didn't have enough people to support the needs of the seniors.
If we were going to reopen, and we knew that we needed a certain level of reopening, a higher level of reopening, why did we not roll out more widespread testing and screening? We now know from the fall is that Western jurisdictions, all of them pretty much, need a level of reopening that goes beyond what we can support with testing symptomatic individuals and then contact tracing. And that's equally true in long-term care. By the time you find someone having symptoms, orders a test, gets the test returned, contact tracing or public health measures are initiated, that first person's infectious period is largely over, or maybe it's 2/3 or half or 3/4 over. So they may have already infected others without knowing that they were ill, even before they got symptoms and had the test.
Is there an opportunity around incorporating rapid testing, point of entry, in addition to the screening questions and the PPE use and the engineering controls and the administrative controls, all the stuff we love to talk about in occupational health and safety? Can we not find a way to integrate more testing as a screening mechanism rather than using it as a diagnostic tool once the outbreak started? Because one of the things that we've seen really clearly is that once COVID gets in the door, it's really hard to stamp it out. We have multiple examples where an individual who is asymptomatic ends up testing positive for COVID-19. But one of the tools that we have not yet taken advantage of is that concept of using rapid tests not as a diagnostic tool, but as a screening tool. Because one of the things that rapid tests can be quite effective at doing, if they're administered regularly, is catching those asymptomatic people. The challenge is right now, we don't have a regular testing regime in long-term care. We're not testing staff regularly. We're not testing residents regularly unless somebody has a positive test or somebody's showing symptoms. And oftentimes, if you have one case, chances are you already have 2 or 3, you just haven't found them yet. And it's interesting because we've seen the adoption of testing as a screening technique in the travel industry, we've seen it in the film industry, we've seen it in professional sports, but we haven't done it here in BC in a healthcare setting. In particular, the settings where we are having the most deaths and the greatest number of outbreaks.
Good afternoon, Minister. Good afternoon, Dr. Henry. The Seniors Advocate, BC Care Providers Association are both saying that rapid and regular testing of staff in long-term care would be a helpful tool to help contain and identify the growing number of outbreaks in long-term care. It's being done for hockey. It's being done in the film industry. Why isn't it being done in long-term care here in BC?
Yeah, so I saw that. There was reference to some of the rapid tests that have been, we've received in small amounts here in the province and in the country. So the short answer is that the testing is not available in what they were describing. But the other part that we need to look at is where this has been done in other provinces, it is not a panacea. It is not what is going to solve our issue because the tests have faults and limitations, and you'd have to test everybody every day. And yes, they certainly do it in some sectors for short periods of time, but the yield and the volume of testing that would require is not at the point where it would be helpful for us instead of the regular screening that we are doing every day.
From what I've seen from BC Centre for Disease Control, about 2/3 of the deaths in BC from COVID-19 are long-term care residents. I keep hearing from long-term care residents who they say it's not us, it's not the visitors, it's got to be the staff. Doesn't the rate of the spread here and the death rate lend a sense of urgency to doing more than's being done?
You know what? I can't say that there is more that is more urgent to us than doing everything we can in our long-term care homes. And I'm not sure that I know of anything more that we can do.
After months of lobbying, public health officials finally endorsed rapid testing for BC's long-term care homes in March 2021.
Did we do enough? And I don't ever want to be in a position to question that.
On Halloween 2020, as COVID-19 was spreading rapidly in care homes across the province, an outbreak started in the Fraser Valley that would become BC's largest to date.
Usually our residents are very complex care residents. They're very fragile. They're at the end stage of their dementia.
Tabor Village is a place that almost 300 people call home. We have complex care, 2 buildings providing complex care, Tabor Home, 118 people live there, and we have another campus called Valhaven with 26 people living at Valhaven. We provide care from the heart with Christian compassion, respect. It is a vibrant community. On the weekend of Halloween, October 31st, I was alerted that one of our staff members had gone home with symptoms that were COVID related. And we prayed that her test would be negative, and up until then, all the tests had for months been negative. So we just assumed to be negative, and when we found out it was positive, we started doing the contact tracing and realized that we better test a whole lot of people. Our worst nightmares came true, that we had an outbreak and that had already spread before we even knew we were in the middle of an outbreak.
We felt so much fear and anxiety. We just felt like, oh, what if it comes to us? What are we gonna do? Are we safe here? Or are our seniors safe here?
And it just was going like wildfire. We just couldn't seem to contain it. And I think the overwhelming tragedy for me was that, are we doing everything right? Are we doing our PPEs? Because we felt a lot of blame and a lot of guilt because it was spreading so quickly to our residents. So it was really vicious in the care home, and families were beginning to wonder if we were doing everything that we should be doing. But we were. We were following everything that we could possibly do. For 69 people to suddenly rapidly come down with COVID within a 2-week period, it was kind of unbelievable. It was unbelievable. It was very, very hard to control. And 10 of our managers tested positive. So on a floor where there was other managers, there was only myself and one other manager that tested negatively. It was an overwhelming virus, and it had attacked their staff. They were asymptomatic, so they were coming to work with no symptoms.
3 of us were having lunch in the lunchroom, and we had a pleasant day. We discussed Halloween, and of course, no one was going to be going anywhere. We were going to have a quiet evening, and it was just a real great day of visiting. Tuesday, I arrived back at Tabor to see a notice up that there was an outbreak in the building, and I was not well. I found out that the 2 I had lunch with had tested positive. So that was sobering. I put myself into isolation and I went to be tested. And so my test came back via text with my name, and it did say positive.
Lockdown was declared at Tabor Homes, where I work. The lockdown had brought so much loneliness among our seniors. They feel so isolated. They kind of lost the connection with their family. More than 150 people in our facility contracted COVID. 93 residents, 63 co-workers, 26 of our residents passed away. These are the residents that we have known and cared for many years. We are their care providers, but also we are their family and their friend. It's hard. Excuse me.
We were the survivors, and we had gone through We hadn't gone through Bosnia or any of the battlefields, but we had gone through our own battlefield, and we were like the fatigued soldiers, really.
It took me 3 weeks to get back. I was chafing at the bit. I so badly wanted to get back. I just thought, what have we just been through? We had family members that would come to the window. It was especially this one wife who would come in to see her husband. And she would come in and say to him, "Have you forgotten me?" And he would say, "Never." And she would say, do you still think about me?" And he would say, "I always think about you." And then she would say, "Do you still love me?" And he would just, "Of course I love you. I love you." I particularly watched this couple from week to week, this husband who had kept declaring his love for his wife, passed away. I just wasn't sure how his wife would possibly handle that. First of all, not being able to be together and the longing that someday they would, and now it never would happen. One of my clients, she was a former teacher. The one that's turning 100 next month, she was a nurse. My father-in-law did amazing things in his life. So these are the people that once were valuable members of their community and environment, and these are the people that now are in these nursing homes. And possibly it is a moment to take another look at what's happening and how care homes are and how long-term care aides are, the value of what they've done.
From working in the field, also realize the ageism that we see in society and how critically valuable older persons are and the rights of older persons. And that's really what's compelled me to want to enhance the lives of others. The toughest thing was knowing that the rights of older adults were probably violated in many care homes like Tabor, which really is the opposite, the antithesis of why we exist. We exist to enhance the lives of seniors, and here we had an outbreak that was basically challenging our very existence.
You know, put yourself in someone's shoes who is 85. What are your expectations of the healthcare system? And would you expect it wouldn't matter what your age is?
We can't talk about what's happened over these past few months unless we address the elephant in the room, and that is the fact that we live in an ageist society. I don't think it's controversial to say that. Ageism is probably one of the last acceptable isms we have in society. And a lot of the challenges and the issues facing the continuing care sector have their roots in that ageism, and that's something that we all have a hand in. We see it in how we value and elevate certain healthcare professions. We see it in what causes we donate our money to. We see it in our hiring practices. We see it in what we value in investing as taxpayers. We see it even in how, as individuals, we either adhere or we don't to the public health orders.
There's so much feeling of frustration when we see people disregard the public health order to stay safe. It's kind of selfish of them not to protect themselves in order to protect others around them.
Folks don't often think about seniors' care. Everyone loves their grandparents, everyone loves their parents, no doubt about it. But I think a lot of folks don't realize or don't recognize some of the challenges of that world, and some of them don't even know that that world exists.
there is an element of ageism in our system as well as in our society.
I think that's a big elephant in the room that we don't talk enough about. And the ageism issues or ageist attitudes are both implicit and explicit, and they impact on many levels.
Nobody wants to go to a long-term care. There have been surveys where seniors have responded that they would rather die than go to a nursing home. So that's pretty dramatic. That's dramatic, but it is true. But by and large, this is not a positive option in our seniors' mind, and we need to change that.
I am the president of the International Longevity Centre of Canada, which is a human rights-based organization that really looks at the needs and rights of older people. My organization began at the University of Columbia in the United States by a very famous geriatrician named Dr. Robert Butler, who actually coined the term ageism back in 1969.
Ageism refers to prejudice or discrimination on the grounds of a person's age.
And our organization, which has 16 Global Alliance centers around the world, has really focused on the whole issue of ageism, and we view all our work through that lens of human rights and battling ageism. My brother-in-law in BC died of COVID. His name was John Fox. He was 73 years old, and he was a very vibrant ex-RCMP officer, activist in his community, a vibrant person, and he was struck down very quickly. He got sick and was dead within 10 days. The day he died, the announcer said, 4 dead in BC, all elderly. And at the time, we were starting to see the different treatment that the press had towards people who were older and dying of COVID and those that were younger. And I think that was certainly an example of that. And it was interesting because it sort of summarily dismissed all that those older people were in terms of being, all that they contributed to society, the work that they did, the people they loved and the people that loved them.
If we want to walk into a park right now and go visit with a family member, physically distant, or a friend, we're allowed to do that. We're allowed to see people within the public health orders remaining physically distanced, and we're allowed to go for a walk with them. A senior in care is denied access to their families, and for far too long, we've seen only even a limited number of essential visitors. And that whole situation, we're balancing the safety and the rights and freedoms of the seniors. I don't really think we've asked the seniors in care what they would like. We don't do that to prisoners. Even incarcerated people get an hour of outside time. In nursing homes, we don't have to do that, and we should be doing that. That should be mandated. We haven't given people the rights there. But I think the biggest rights that we've denied them is the rights to seeing family members. And that's something we have to restore as soon as possible. We've got to figure ways of doing that. If it's not virtually, it's got to be done in a safe way, but really denying them the access to their family members and their friends is something we have to change immediately. And I think we've got to balance that with safety, but ultimately, at the end of the day, we've got to give them the choice to be exposed to that risk if they choose to.
In sort of recognizing that, hey, there was a blind spot before, we recognize it, but there's no time to really complain about that. Let's move forward and find a solution. And I think if there was no COVID, we probably wouldn't be strengthening the seniors care sector. It is up to us to really ensure that what is happening now doesn't happen again.
And somehow we have not served these older people who built our country, who contribute to the economy that we have, and the social justice and the systems we have. And we've left them in these situations that are just horrific and so wrong. This would never have been allowed to occur in any other institution, whether it was, think of a school or a hospital or a daycare. If you think of a place where, say, 20 people died or 40 people died in that institution, what our response would have been as a society, I think it would have been swift and clear interventions and changes to the system. But what is interesting in that is that our systems were broken for older people ahead of time. Obviously we have issues where people, deal with isms, whether it's racism or sexism or homophobia. But, you know, we talk about them and we address them. And this kind of mass death, you know, just hadn't been seen before.
When I saw acute care hospitals empty out, when I had calls from personal friends of mine who said to me that they were working in emergency rooms that were essentially empty, that they didn't know what to do because it was so quiet in acute care. And I had to field calls from care home workers who had worked a 12-hour shift and then were asked to work again because people were calling in sick, there was nobody at work, and yet acute care hospitals were overstaffed. And I look back and I say to myself, if we've learned anything from this pandemic, anything from a pandemic that relates to a respiratory illness, please never again shut off our hospitals to our seniors. Never again, you know, when we're trying to transfer them to an acute care to receive the care that they need, we should never again tell them stay in a long-term care home and die there.
The staff were, you know, sort of jumping up and down this morning. We have a lot of excitement. We were waiting to do our second vaccine shot this morning, and it was delayed last night in a shipment from Toronto. So the actual supplies were delayed. So we're pretty excited that everybody, we're going to have 87 residents vaccinated with their second shots this afternoon. So we're pretty excited that we're doing that.
Day that the vaccines came, it was like quite a change. There was just joy, excitement, relief, going from room to room, and the residents were vaccinated. So I would say there was a turnaround in terms of just hope and relief and excitement that we had the vaccine.
I do think, you know, pandemics would have a beginning, a middle, and an end. And the beginning of the end is probably not until summer or maybe even early fall. For long-term care in particular, that's the population we should be prioritizing for vaccine. I think we are prioritizing for vaccine. And I hope that we would see the impact of vaccine on deaths in long-term care very, very soon, you know, in a matter of 3 to 6 weeks. So hopefully that most tragic piece will have an end that is much sooner than the end for the rest of us.
In many ways, this has a lot of the same challenges around it that the PPE issue did too. We're going to be challenged in our distribution efforts like we've never been challenged before. We asked our members in continuing care, what are your intentions around getting vaccinated and what are your questions? Because we didn't want to go forward with the assumption thinking that everybody would be 100% on board and they're happy to roll up their sleeves and away you go. The vast majority of people did intend to get the vaccine. There was also a significant percentage of people who weren't sure. And the primary reasons that they weren't sure were really they had questions about side effects and how the vaccine could have been developed so quickly and still been rigorously tested. These are all really natural questions to have, totally understandable. And so for us, having that information, being able to share that information with the Ministry of Health, being able to share that with the sector at large is really powerful because there are answers out there about what the side effects are and about how the vaccine was rigorously tested. We just need to make sure it gets to those people who have those questions.
It took a pandemic to get seniors living in long-term care and their care providers to the front of the healthcare line. Will they stay when COVID ends? Will governments and healthcare authorities finally implement long-standing recommendations to fix a frail system? Or will the rights and quality of life of residents and staff fade to the margin again until the next crisis in care?
I hope that a light has been put on the sector and that the cracks that have really existed for decades have been exposed.
I think the high percentage of deaths in long-term care for the Canadian scene is a really strong wake-up call. Some of the measures that we have been talking about for years, small-scale group home, single occupancy rooms, easy access to common spaces, access to outdoors. Some of these are actually not only helpful for person-centered care, social model of care, but they're also helpful in the context of pandemic preparedness.
The concern is that we don't want to make our long-term care into an acute care setting. We need to recognize the distinction that we have been looking at, we have been talking about, advocating for at a personal level, a professional level. Many organizations have been working towards changing the culture of long-term care from a more biomedical, clinical model to a more socially oriented model. The next year, I think in my mind, is a critical year for those to take shape in some meaningful way to have lasting impact. And I hope that a few years later, we are looking at long-term care in a whole different way, where it is what we're aspiring for to be not only a safe place, but as a positive option for living for our seniors. But we need to have a strong sense of urgency to make some decisions about national standards in long-term care, what are the critical components of the national standards, and how do we make decisions on those standards.
And then think about how we can change it so that we recreate, reinvent, re-engineer our living environments for seniors such that these outbreaks that we heard about in the news, that we read about, that we were horrified, that were our worst nightmares, never can happen again because we've made that change.
It's inspiring to see change start to happen. I guess that's one positive thing that the pandemic gave us was a focus on the needs and rights of older people, and I think an understanding that this is not who we are as Canadians and we need to fix it. And I hope to God that Canadians stand up and demand that their governments do a better job.
Health human resources was the biggest challenge. It is the biggest challenge we have right now. In British Columbia, we are now aware that we need 7,000 to 10,000 additional workers just to fill the vacant spots that we have that were being filled by healthcare heroes that were working multiple jobs. And that's not even taking into account that retirements are happening and burnout is happening.
Anybody who puts themselves behind the needs of others deserves our incredible support and thanks. And they really haven't been professionalized and met with the kind of wages and benefits that they deserve. And I think part of the reason is because we see that it's a profession of women taking care of women. And I think there is some sexism, especially with ageism, and they are often from minority groups. So I do think that there's some discrimination that appears around the sector.
I can take a few minutes and clap and cheer and honor them in my own little way. When Dr. Bonnie closed us down in March, I think it was the 17th, I decided after a couple of days that it doesn't matter if I'm on my own, I don't care. And I went out to my front deck and I clapped and I cried. Not because of COVID, but because of this huge movement of honoring all the frontliners. I just felt so small to be a part of it, and it just made me cry. We're just trying to be a little bit of good for them. My Italian neighbor did it for a couple of days. She was all in. And then Jason Cresswell, our music man, he started playing O Canada. And of course that made me cry. And then he decided that he would play a great song every night, and more people came out. And within probably 2 to 3 weeks, the 8 houses who are here tonight are here every night. The kids all through the summer, they hardly missed a day, and they scoot around and they're fun. So I went to their parents and asked if I could give them a little payday on Fridays after a couple of months, because they were out every night. So they get paid on Friday, a little bag of candy, and they understand what it's all about. It's fun for them too, though. And we're all out here for the same reason, but it's twofold now, because now it's a social event. Now we are a neighborhood. We are a tight group of people, and we're all friends. And we weren't all friends to start with. We didn't know each other very well before, all of us. And so that's why we do it. My friends say, I can't believe you're still doing it. Good on you. And everybody else, I'm not sure if they will continue or how long they'll continue. I want to do it until quite a few people have been vaccinated and there's actually a light at the end of the tunnel.
Our staff have a very heightened awareness. They've been through the worst nightmare of their careers, and they do not want to go through this again. And so, they have learned, we've all learned. And so, yeah, I think we're better equipped. We just can't wait for a vaccine.
Many don't even understand the pressures and the capacity issues that long-term care operators and the sector as a whole faces. Many don't understand the work that's being done, the tireless, God's work that our healthcare heroes have been doing. And I think the pots that were being banged at 7 p.m. every night, and the parades by the first responders, and the notes from celebrities and from media as a whole, and from politicians as a whole has helped with that.
For every negative media news and report you've heard and everybody has heard, there's thousands of positive stories on what a human can do to elevate themselves into hero levels. And the other thing about this group is they don't wait for you and me to thank. They don't expect a thank you card in the mail. They just do it because it's their nature. They feel the need to, that basically this needs to be done, and I'm there to do it.
Hello and greetings to BC's healthcare assistants. I'm Dr. Bonnie Henry, BC's Provincial Health Officer. As a physician and in the role that I play, I know what important role healthcare assistants play across our healthcare system. Our healthcare system, as you well know, is a very complex machine that needs all of us working together to support and care for the people in our province. And you are vitally important to making sure we make that happen. In the last few months, everyone in the healthcare system has been put to the test by the COVID-19 pandemic. Yet I have seen and heard so many examples of people rising to the challenge. I want to thank you for all that you have done and all that you continue to do each day. The work you do matters. It matters to everyone in BC.
And I hope you're all taking a moment today to celebrate you and all that you've done for our country. Every day, Canadians owe you, our healthcare assistants, a debt of gratitude for your service to our country and to our communities. Your professionalism and warmth is comforting to so many. But I know this year has been particularly tough for many of you as you work on the front lines in the fight against COVID-19.
I myself was tested positive of COVID-19. And my greatest fear is if I have to pass this on to my family, a coworker who was tested positive of COVID. We work in the same unit. She infected her husband and one of her young children. Another coworker who I work with in the same unit had returned to work, but recently found out that even her internal organs were badly damaged. This is just incredibly hard for us to take. Working in a long-term care facility at Tabor Home is such an enriching experience for me. Some days it's so exhausting and overwhelming, but overall, it's a rewarding job. The quality of care that we share to our residents defines the quality of life that they so deserve.
I think it goes right back from almost when I was born. We lived next to my grandparents out in the country. I was also spent a lot of time with my other grandmother, so I was very, very close to my grandparents. And I would say that's what propelled me towards being familiar with elders, loving elders. I would say that I attribute the influence of my grandparents to where I am today. Through the management, they formulated a position for me that I would now go back full-time as a visitation host. I was to be only with the COVID residents because now I'm safe, they're safe. I was also to do more family connection, and I was also would be sitting at the bedside of those that were passing. When I was finally back in full on, I had my cap on, my goggles, my mask, my gown, my gloves. And the first one I went into was the one also I've looked after for many years. Love her dearly. And she had COVID, and I had asked if I was allowed to hug, and yes, I was allowed to hug. So I took her and wrapped her up in my arms. And she broke out in laughter. She laughed. And it was like in the middle of the chaos, she broke out in laughter. And I thought, she's going to recover. And she recovered. Many of them have actually recovered, even though we had big losses.
One of the ladies that actually succumbed to the disease was a school secretary. And she was a lady that wore pearls every day and dressed up and wore makeup. So it was very hard to see her decline. And her sister lived on the island. So, my background is Irish Catholic. So it was very hard for me not to allow her sister to come in. At that time, we were told no visitors, no essential visitors even. This lady wasn't end of life. And so on a daily basis, we took the iPad in all covered in the saran wrap. So the two sisters talked every day. And it was really tough on us because when we did the tracing back, it traced back to some of our care staff and to some of the staff at the site. So it was very hard on the staff to accept that. And a lot of the staff would break down during the day and start crying.
I'm not going to worry about what tomorrow brings. No. I'm going to enjoy that hug, keep hugging. Mm-hmm.
If you watch ABC on Monday night, you get to watch the emergency room. If you watch NBC on Tuesday night, you get to see a show about doctors. But no night of the week do you get to see a show about care aides working in long-term care. They never did get the attention and the recognition they deserve for the amazing work that they do each and every day, taking care of our grandma, our grandfather, our loved one, someone, our great aunt, someone that we've had in our family that we can no longer care for. And sadly, they got onto television, and they finally did, and they got on for all the wrong reasons. They got on because of COVID, And they're now bumping those other programs, and it's a real life drama that unfolded every single day in long-term care. And these individuals went into work every day. They put on their PPE, they left their families, they went in to take care of our loved ones and to protect them. And they did it at an incredible cost.
On the outside, we look so strong and resilient in the face of COVID. But deep inside, underneath us, we're barely keeping it together. We don't want another COVID outbreak. I don't know if we're gonna survive another one.
Anybody that is a caregiver is there because they love people. That's who they are.
When you're in a time of crisis, sometimes you need that top-down command and control structure, the I'm going to tell you what you need to do now. And that's necessary. But then there also needs to be, at some point, that ability to have feedback back from the sector, because these people who are working on the front lines, who are day in and day out doing their very best to keep everyone around them safe and healthy, they are our eyes and ears. They understand this like nobody else. And we need to listen to them. And so for me, that's the one major takeaway, is that we always need to stay connected and close to the front lines of where this is happening, to listen and truly listen to what's going on from their perspectives, because that's the only way we will be able to get information fast enough to understand what the next challenge is going to be, or whether what we're doing is having the intended effect.
Call this meeting to order. Welcome to meeting number 15 of the House of Commons Standing Committee on Health.
Good afternoon. My name is Maria Dreyfus.
I got a call. Maria, will you tell your story to the House of Commons?
There's so much fear and anxiety. But when the big outbreak hit our site, it was totally devastating.
I could not tell him I was shaking because it's cold or I was shaking because I'm nervous.
This cannot happen again. A quicker response was needed. We needed better communication about the virus, about the PPE required to protect us to the fullest.
At the end of the session, I got the last question, which I did not expect.
What would mean the most to you and your fellow workers in the sector that you work in? What advice would you give us?
I only ask for one thing: time.
It would really mean a lot to us if we are able to do our job, direct care, without being rushed at work, and being able to spend time, quality time with our residents.
I heard from his spouse last night, and I brought an email I thought I'd read. She said, "It's so nice to hear from you. I went back to work last October, and life for me is very tough right now without my husband. Going back to work and making arrangements of who's going to pick up my daughter at school, things will never get better. But I'm trying to be strong for the sake of my daughter. Every time my daughter will say, 'Mom, I'm going to ask Jesus that when Daddy is done helping him in heaven, Dad will come back to earth and be with us,' which will never happen because her dad is gone. It's very devastating, tragic, and very painful that we lost her dad. It is also heartbreaking every time she says she misses her dad so much. Life is very unfair.